Welcome back to 10-Minute Community Medicine. Quickly, please subscribe, like this episode, and drop your next topic in the comments. Your picks shape our revision lineup. Today's focus is xerophthalmia, the spectrum of eye disease due to vitamin A deficiency. Dr. Joshi, could you start with a crisp definition and why this matters for exams and clinics?
Xerophthalmia is the ocular manifestation of vitamin A deficiency ranging from night blindness to corneal destruction and scarring. It is both a clinical emergency and a public health signal of undernutrition, repeated infections, and poor dietary diversity. Examiners love it because it spans the continuum: individual case management, nutrition, immunization, and program strategies.
How would you frame the essentials, definition, determinants, and the classic staging?
Definition you already have. Determinants include poor intake of animal sources and keratin-rich foods, malabsorption from chronic diarrhea, low-fat diets that impair absorption, protein-energy malnutrition, measles, and early weaning without adequate complementary feeds. Now staging. Quote the WHO classification with names and codes: night blindness XN, conjunctival xerosis X1A, bitot spots X1B, corneal xerosis X2, corneal ulceration less than one-third of cornea X3A, keratomalacia more than one-third X3B, corneal scar XS, and xerophthalmic fundus XF. Always document both eyes and the worst lesion for staging.
Case Vignette 1. A 3-year-old from a drought-affected block presents with night blindness and foamy patches near the limbus. Growth chart shows undernutrition. There was measles 1 month ago. What is your diagnosis, immediate management, and counseling?
Diagnosis: xerophthalmia with XN and X1B, at high risk of progression. Immediate management is high-dose vitamin A as per WHO's therapeutic schedule. For children 12 months and older, give 200,000 IUs orally immediately, day 1. Repeat 200,000 IUs on day 2 and a third 200,000 IUs 2 weeks later. For 6 to 11 months, the doses are 100,000 IUs. For less than 6 months, 50,000 IUs. If corneal involvement is present or the child is vomiting, give the first dose intramuscularly and ensure urgent ophthalmology assessment. Add broad-spectrum topical antibiotic, cycloplegic for pain, and nutritional rehabilitation with fat-containing meals to aid absorption. Counseling: resume age-appropriate feeding, add green leafy vegetables, orange-yellow fruits, eggs and dairy, complete measles and MR immunization, deworm if due, and return for the scheduled third dose.
Many Viva questions ask, what makes xerophthalmia a public health emergency? How do you justify that?
Because corneal ulcers in deficiency can liquefy within hours to days, ending in irreversible blindness. Also, a diagnosed child indicates similar risk among siblings and neighbors. So one case implies a community-level nutrition and infection problem needing immediate outreach, screening, supplementation, and food-based solutions.
Shift to apply. What are the community strategies to prevent new cases and recurrences?
Use the 4 Ds. Diet diversification. Promote family foods rich in vitamin A and carotene, dark green leaves, carrots, pumpkins, papaya, milk, ghee, eggs, liver. Cooked with a little oil to enhance absorption. Doses. Prophylaxis. Under the national program, give prophylactic vitamin A, first dose 100,000 IUs at 9 months with measles or MR vaccine, followed by 200,000 IUs every 6 months up to 5 years of age as per the current state guidelines. Disease control: prevent and promptly treat diarrhea and acute respiratory infections, ensure measles immunization, deworm periodically to improve absorption. Delivery platforms: leverage Anganwadi centers, village health and nutrition days, outreach by accredited social health activists, and school health sessions to find and serve children who missed doses.
Could you link program science with individual care? How does measles tie into xerophthalmia prevention?
Measles depresses vitamin A stores and inflames ocular surfaces, so deficiency precipitates severe keratopathy. Giving high-dose vitamin A during measles reduces mortality and ocular complications. Hence, MR immunization at 9 to 12 months plus the second opportunity later on is a xerophthalmia prevention strategy, not just infection control.
Let us analyze what barriers derail success and how do we counter them?
Barriers include irregular supply of vitamin A solution, caregiver beliefs against supplementation, poor palatability, and weak follow-up systems. Solutions are to maintain buffer stocks at sub-centers, decant into smaller, light-protected bottles with marked droppers, train workers to demonstrate dosing, use reminder slips and community WhatsApp groups, integrate dosing with immunization and deworming days to reduce missed opportunities, and celebrate visible improvements. Caregivers trust what they see.
Examiners often ask for investigation pointers. Do we need labs to diagnose?
Xerophthalmia is a clinical diagnosis. Biochemical tests like serum retinol less than 0.7 micromole per liter or a positive relative dose response test are useful for surveys and research, not for delaying therapy in a symptomatic child. In practice, treat first, then address nutrition and infections.
Before we evaluate, could you give a high-yield list of do's and don'ts in corneal disease?
Do's: start high-dose vitamin A immediately, protect the eye with antibiotic ointment and a shield, use cycloplegics for pain and refer urgently if ulceration is present. Do ensure systemic hydration and nutrition. Do not patch tightly over suspected keratomalacia, do not use topical steroids, and do not delay treatment awaiting labs or referral.
Common pitfalls students make?
Forgetting to stage with codes, mixing bitot spots with pinguicula, quoting only therapy and ignoring diet and measles, and omitting the 2nd and 2-week therapeutic doses. Fix it by pairing every stage with one action and every action with one platform.
Could you leave us with a write-ready exam skeleton?
Start with definition and determinants. Write WHO stages with names and codes: XN, X1A, X1B, X2, X3A, X3B, XS, XF. Add pathophysiology in 2 lines, clinical features stage-wise with one distinguishing point for bitot spots. Management is therapeutic dosing scheduled by age, ocular care, nutrition, infection control, deworming. Prevention, 4 Ds: diet diversification, doses, prophylaxis, schedule, disease control, delivery platforms. Program monitoring via coverage, surveys, and outcome metrics. Close with one emergency line, that is, corneal ulcer in deficiency is time critical, treat immediately.
Pause and reflect. Can you now recite the therapeutic schedule, name 2 dietary sources, and list XN to X3B without notes? If yes, you are exam ready. That wraps Xerophthalmia. If this helped, subscribe, like, and tell us the next topic.
Keep practicing the stages and doses, pair clinical action with community strategy, and your answers will be precise and powerful.